The chest radiograph shows ill-defined opacity in the right mid-zone, obscuring the heart border. Ill-defined opacity in the right mid-zone, obscuring the right heart border. Left review shows thin red-shaped opacity. Left review shows thin red-shaped opacity diagnosed right middle lobe collapse. Okay, okay, this is one. Question 48. Which feature would indicate chronic rather than acute trauma on the CT? Peripheral mural filling defect forming obtuse angle with wall. Which feature would indicate chronic rather than acute trauma on the CT? Peripheral mural filling defect forming obtuse angle with wall. Remember that chronic thromboembolism, there's obtuse angle forming with wall, and chronic thromboembolism also has mosaic pattern. 49. Crazy paying pattern appearance diagnosis pulmonary alveolar proteinosis. Crazy paying pattern diagnosis pulmonary alveolar proteinosis. Crazy paying pattern diagnosis pulmonary alveolar proteinosis. This is also pulmonary alveolar proteinosis. Crazy paying pattern. 50. Which features of the mass would make hamartoma more likely than carcinite? Presence of fat. Knowing that in hamartoma there is presence of fat, so it makes it more likely than carcinite. Which feature will make the mass more likely hamartoma more likely than carcinite? Presence of fat. This is simple. Question 51. Dialysis shows abnormal UA and creatinine. CT scan shows fluffy nodular 5 to 10 mm opacities of air-space type appearance with foci of calcification in the upper lobe distribution, calcification of chest wall vessels seen, postmortem diagnosis, chronic renal failure. Chronic renal failure. This is on CT scan shows fluffy nodular 5 to 10 mm opacity of air-space type appearance with foci of calcification in the upper lobe distribution and calcification of chest wall vessel. Diagnosis: chronic renal failure. So memorize this. Chronic renal failure. Question number 52. Meinberger shows CT scans with multiple small nodules up to 5 mm with a solid shaped mass paralleling the mediastinum. Diagnosis: core pneumonogenesis with progressive massive fibrosis. Okay, this is diagnosis of silicosis leading to pulmonary progressive massive fibrosis. Silicosis leading to progressive massive fibrosis. But here is called same thing nearly. CT scans with multiple small nodules of 5 mm with a solid shaped mass paralleling the mediastinum. Solid shaped mass paralleling the mediastinum. Diagnosis: colloquial pneumonosis with progressive massive fibrosis. Question 53. History of recurrent chest infection of the child. This graph shows hyperlucent left lung. Diagnosis: McLeod syndrome. Now, hyperlucent left lung, either McLeod syndrome or Swyer-James syndrome, they are both the same thing. This is Swyer-James syndrome. This is pneumothorax, left side pneumothorax. So this is Poland syndrome. Poland syndrome, because there is no pectoral muscles, and this is Swyer-James syndrome. Both have hypertranslucent single lung zone. So here is chest radiograph with hyperlucent left lung. History of recurrent infection as a child. Diagnosis: Swyer-James syndrome. There is also small left hilum. Swyer-James syndrome or McLeod syndrome are the same thing. Question 54. Most typical description of myxoma is left atrial mass, enlarged left atrium, calcified lung nodules, and pulmonary edema. Like this is pulmonary atrial myxoma. The atrial myxoma, cardiomyxoma, and this is pulmonary embolism. Now, there's most typical myxoma is left atrial mass, enlarged left atrium, calcified lung nodules, and pulmonary edema. There will be. Question number 55. Again, pulmonary embolism will show Pollament sign, question mark sign, or pulmonary embolism. The next question number 55. CT scans shows fatty enhancement of software elements is seen along with vocal calcification and liposarcoma. So from this, we can know that there is fatty enhancement of software elements along with vocal calcification diagnosed liposarcoma. Lipid with calcification diagnosed liposarcoma. Question number 56. Patient has rheumatoid arthritis. The commonest pulmonary finding seen on chest radiograph is pleural effusion. Patient has rheumatoid arthritis, common as pulmonary findings on chest radiograph is prerequisite. Question number 57. The chest radiograph shows a smooth curvilinear tubular opacity adjacent to the right heart border. Smooth curvilinear tubular opacity adjacent to the right heart border. Diagnosis: Scimitar syndrome or partial anomalous pulmonary venous return. A chest radiograph shows smooth curvilinear tubular opacity adjacent to the right heart border. Diagnosis: partial anomalous pulmonary venous return. Chest radiograph shows smooth curvilinear tubular opacity adjacent to the right heart border. Diagnosis: partial anomalous pulmonary venous return. Question 58. In multi-detector CT angiography of the lower limb, the effect of calcification on images can be reduced between which of the following post-contrast technique: curved panel reformat. Now, in multi-detector CT angiography of the lower limb, effects of calcification on the images can be reduced by use of which post-processing technique? Curved panel reformat. C for calcification, C for curved planar reformat. C for calcification, C for curved planar reformat. C for calcification, C for curved planar reformat. Next question 49. 59. A chest radiograph shows raised left-hemic diaphragm, which demonstrates paradoxical movement on fluoroscopy, most likely caused mediastinal small cell carcinoma. Now, raised left-hemic diaphragm, which demonstrates paradoxical movement on fluoroscopy, most likely caused mediastinal small cell carcinoma. Raised left-hemic diaphragm, which demonstrates paradoxical movement on fluoroscopy, most likely caused mediastinal small cell carcinoma. Other options don't make any sense. Check question number 9. 52-year-old male with mild dyspnea, chest radiograph shows raised left-hand diaphragm, which demonstrates paradoxical movement on fluoroscopy. Most likely cause is mediastinal small cell carcinoma. It can be pancreas tumor, not left lower lobe tumor, not infiltrated, not cerebrovascular accident. Question 60. A 6 cm abdominal aortic aneurysm is seen. What advice should be given? Emergency assessment by vascular surgeon. This is an diagnosis of aneurysmal dissection. Aneurysmal dissection. This is a chest radiograph showing well-defined enlarged left heart border with indistinct lateral border. But this is aortic dissection. And when there is 6 cm abdominal aortic aneurysm, then what should be given? Emergency assessment by vascular surgeon. This is greater than 5 cm or 5.5 cm. This is again left ventricular aneurysm. This is left ventricular aneurysm. But these we will discuss in talks in detail. Now, if there is 6 cm abdominal aortic aneurysm, should be given emergency assessment by vascular surgeon. Question number 61. Solitary pulmonary nodule. This is thrombosed aneurysm. Question 61. Solitary pulmonary nodule, chest radiograph which in scan should be arranged 18 FDG PET or CT scan. Solitary pulmonary nodule on chest radiograph which in scan should be arranged 18 FDG PET or CT scan. Question number 62. Vessels supplying the signer SA node most commonly arise from which structure? Right coronary.